total body PET is another term for stretching out the axial dimension of a PET scanner. So right now, most PET scanners are about 20 centimeters, and they'll take a chunk of the body at once. And you get those whole body scans by basically moving the patient through that one chunk scanner, kind of like you do a CT. So you image and you just go ka-chunk, 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 and move the patient along and get the whole body. These devices are kind of more generically called long axial field of view. When you do what Davis and the United Imaging out of China have done and make a full 2-meter device, yes, that's whole body. At Penn, we decided to go for 140 centimeters, which is whole body, but we have to give up the feet, which we're okay with. And you don't have to give them up. You can just move them to that site, but usually the feet are not that important unless you're looking at foot diseases, in which case you can just shift the whole frame of view. The one that Axel was talking about in his talk at ESMO is the commercial Siemens device, which is the second commercial long axial field of view device out there besides the Chinese United Imaging device made by Siemens, and that's 100 centimeters. So for 100 centimeters, you don't get the whole body, but you get enough of it that in most cases, it gives you the landscape of what you need. So these devices do two things. In nuclear medicine, we're always limited by the number of counts we get. And unlike almost every other modality, we're just limited by the noise of the data because of that. Part of the reason is we just don't want to give anybody too much radioactivity unless we're actually trying to treat them, which we're usually not. And the other thing is just so long people can lie in the scanner and wait. These devices are probably about 4 or 5 or more times more sensitive. So you can do the scan probably, since you're taking the whole body at once, maybe 10 times as fast, 10 to 15 times as fast. You can do it with much less dose. So if your consideration is dose limitation, as it is in pediatric patients, this may make a huge difference because you don't have to give as much radioactivity. And because you can take these images fast, the image quality is extraordinarily high. You get much more counts and the patient's not moving. Right. That's how CT got so much better. It got so fast. The patient wasn't moving during the CT scan. So I think these are going to improve image quality and they're going to get it done faster and at lower dose. So if you're a clinician, your biggest problem is how to get people on and off the scanner fast enough to pay for them. I'm joking, only half joking, is that, to really leverage these for the full realm of the clinical practice, you almost need a conveyor belt to keep people moving around the system because you got to get them loaded on and positioned. And frankly, like it is with CT right now, it takes more time to get people on and off the scanner than it does to do the scan. That's the clinical cell. The scientific cell from the backside is that we move from a imaging approach that can give us a picture of a tumor or a portion of the tumor burden at once, but we can't get the whole body. Now, all of a sudden, we can actually put the patient in the scanner and not just take a snapshot, but look at a snapshot over time. And one way to think about a PET radio tracer is it is the world's best opportunity to do non-invasive kinetics. So if you did the whole body, pharmacokinetics, so if you did the whole body with a tracer or maybe a labeled drug, you have dynamic whole body pharmacokinetics where you can get 60 minutes of really unique information about delivery. And you can probably bring the patient back as late as 24 hours and get retention information, which we've never had the capability to do. So if you're a drug developer, you go, wow, that's pretty cool. If you're, when I like to think of myself as a translational imager and cancer researcher, this gives you an opportunity to look at factors in vivo biology that you couldn't do otherwise. The other capability that brings those two together is the ability to do more than one tracer at the same time. So if you take a pathology sample and send it off to the pathologist, they'll stain it for a gazillion things as long as they have enough tissue to do that. They'll send it for genomics and you can query a bunch of major genes that way. Right now in imaging, we can really only do one thing at a time. right? But there will be situations where we'd like to do two at the same time. And with PET, that's tough because every positron emitter looks the same to the scanner. But what we can do with this approach is to use a trick we use in other parts of nuclear medicine, is to give a low dose, which is really low compared to what we can do in the clinic, and then a high dose, which would be something similar to what we do in the clinic. And at the same dosing, maybe even a little bit less, do 2 or even 3 tracers at once in the same patient. So one could imagine, to go back to our estrogen receptor example, is doing FDG, which looks at glucose metabolism, and FES at the same time, which is the way we did most of the studies that we did when we were in University of Washington. The reason that's important is that those tumors that lose their ER tend to accelerate their glucose metabolism. The glucose metabolism is, in a very hand-waving way, a marker of dedifferentiation. So if you've lost your estrogen receptor, but your FDG, your glucose metabolism, is still positive, that's how you're going to recognize you're missing something, right? A similar situation is patients who have heavily treated bone disease. It's very tough, short of doing an FDG PET scan, a glucose metabolism PET scan, to tell what's alive and what's not. And if you're looking for the loss of estrogen receptor, you can't just use a bone scan or a CT scan to tell you what you're looking at. You need something that gives you a viability assessment. And again, pairing something like FDG or another tracer and FES not only shows you which lesions are positive, it shows you which lesions are negative, and it's likely to inform each other. We've published data showing that that the level of FDG uptake is often the most compelling marker of the likelihood of progression that may help dictate how you approach treatment, including endocrine treatment. So one of my mentors, Ken Crone, said, remember that 1 + 1 is way more than 2 when it comes to PET, and you bring these combinations together, you learn a lot more about the biology, and there's a lot more to think about from a lot more information that comes from that. Our personal example of that is we actually have one of the earlier cancer moonshots. One of the earlier cancer moonshot grants based upon our whole body PET scanner, where we were using 2 fuels. We actually are now starting to actually do this. We developed technology for it. We're using 2 fuels. One is glucose and one is glutamine. We have tracers for both of those to look at differential fuel usage by the tumors, which we think is not only indicative of their biology, but possibly a therapeutic target.